Uh, so, uh, Today's speaker is Dr. Brody Foy. He is an assistant professor in the Department of Laboratory Medicine and Pathology at the University of Washington. Dr. Foy has a Bachelor of Mathematics from Queensland University of Technology, a DPhil in Computer Science from the University of Oxford as a Rhodes Scholar, and did his postdoctoral training at Harvard Medical School and Massachusetts General Hospital. His research lab focuses on developing and deploying mathematical and computational tools to improve clinical blood work analysis and to better understand hematologic system responses to acute stress. Today, he will be giving a talk entitled, What Does Normal Mean? Mathematical Frameworks for Precision Analysis of Patient Blood Work. So without further ado, I will pass it on to you, Dr. Floyd. Thank you so much.
Okay, great. Can you can see my screen? Yes. And do I need
Yes.
to hide floating controls, etc., or is it just showing the
Uh,
slide?
just the slides. It looks great.
Okay, great. Okay, yeah. So pleasure to be here virtually. Funnily, I'm not actually giving this talk from Seattle. I'm at a conference right now, so I apologize if the Wi-Fi kicks out on me intermittently. I think it should be fine though. So, yeah, I'm going to talk a little bit about various work I and members of my lab have been doing, looking at ways we can better improve how we analyze blood work. This is something I've been thinking about for a long time and very interested in. So, just to give the brief background on myself, so I'm a mathematician by training. I am not a pathologist. I'm not clinical. I started off in kind of pure math or on the border between pure and applied, doing a lot of work in numerical analysis, proving convergence properties of different numerical schemes for solving partial differential equations. Nothing to do with medicine. From that, I kind of drifted into thinking about fluid dynamics in the body, so simulating airflow and blood flow in the lungs to better understand feedback loops. And that got me interested in just thinking about blood as a whole, because blood's really interesting because it's both a fluid and a population of cells, it's a living fluid. And so then I got really interested in blood and blood-based data as a postdoc, and that's kind of led me to where I am now as a faculty. And so really taking this kind of broad view of how we can better think about blood and blood data, and in particular, how we can kind of apply mathematical thinking to medical problems, even if not necessarily mathematical analysis all the time, but just that kind of the ideas that come from a very dynamics-driven math kind of approach. So I'm going to start by just talking generally about blood. Obviously, most people know what blood is, but I think a framework to think about is the complete blood count is the most common clinical blood test in the world. Blood is the front line of a lot of clinical testing because it's very easily accessible via the veins. It's very easy to run tests on blood because they're fluid, unlike tissue structures where you have to deal with the structural kind of component of analysis. And blood interacts with nearly every tissue in the body really closely because of its role in oxygen delivery. So, blood is our front line for the clinic. And the most common test we run is a blood count. If you've ever had blood work run, you've probably had this test run. Typically, what you do is you take some blood, you centrifuge it into its constituent components, so platelets, red cells, white cells, and plasma, and then you give a count of the major cell populations. How many platelets do you have? White cells do you have per microliter of blood? On top of that, you also calculate some kind of distributional characteristics of the cells. So, what is the average hemoglobin content of the red cells or their average volume? And where that distributional data comes from is that you're running these samples typically through a flow cytometer, meaning you're generating single cell measurements. And this is maybe a high level thought to start with, is that we run this test across the world maybe about 1 billion times per year by a back of envelope calculation. And this test involves single cell measurements of 10,000 or so cells of the most plentiful type in the body. We are 85%, 90% blood cells by volume, by number. And the most complex thing we currently do with that data is, say, looking at the mean of a single channel in that flow cytometry of the volume channel, say, or looking at the variance of that distribution. that's about as far as we go. And so a lot of my lab is really set up on this idea of can we extract more data and do more interesting things with the data we're already collecting? Because this test is also cheap. It costs maybe $10 in a US hospital in terms of actual amount of cost to run. And so we have so much data that we're not using, and I want to change that. And there are people in my lab already who are working on interesting things in this problem. So Amber, a graduate student in the lab, is looking at can we take that single cell data and derive new markers that can help us risk stratify patients, for example. To give another example of this granularity problem, we could talk about blood smears. So blood smears, you take a drop of blood, spread it on a pane of glass, look at it through a microscope, and analyze the presence of different types of abnormalities in the cell population. And the current gold standard, if you're looking at, say, a red cell abnormality, is to just say it's present or it's not. There is some push to try and be more specific than that, but current standards at most hospitals are just to say, hey, there are schistocytes present or there are sickle cells present, as opposed to actually quantifying the cell population. And I showed later in my postdoc that if you use, say, computer vision to build a model and actually count those cells, you can do better differential diagnosis of different kinds of thrombotic disorders, say. Or we were able to use this to track treatment response in a patient getting a emergency sympathetic use of a non-FDA approved drug because of a really severe case of thrombotic thrombocytopenic purpura. Which is all to just say that I think there is so much value that we can get out of looking at the data we're already collecting in a much more granular, in a much more detailed way than what current standards are. And this is mostly a precursor to the broader topic of the talk. And to just say that this is not just a blood thing, this is not just a lab medicine thing, this is true across medicine. If we look at clot testing, coag testing, that involves typically shining a light through a clot as it forms or dissolves, and we have a full transmittance curve of the light passing through the clot over time. We don't use that curve, we use a single marker generated off of it. Or EKGs have so much rich data, and we often use simple features derived from them. Or spirograms from pulmonary medicine have the complex breathing pattern of someone, but instead we just look at how much volume they breathe out in 1 second. Or CT virology testing, we have cycle thresholds, but we often just think about the binary, is it positive or not? And so a lot of what the lab does, a lot of what I think about is how we can be more sophisticated in our ways of thinking about these data, particularly the kind of bread and butter data, the things that are collected in all sorts of patients, all sorts of time. So I'm not really going to talk too much about this part, but this kind of is the precursor for a lot of what I am going to talk about. It's this underlying thought that the data we have is really, really rich. But I think the layer I'm now going to add on top, that is what this talk is even when we just consider the markers we already generate from these tests, we don't interpret them well either. And so I want to start with that problem. How do we actually interpret blood tests? So let's say we take our flow cytometry blood count data, we get our white cell count. How do I tell you what that means? We know what it means in terms of the number of white cells per microliter, but what is a good value? What is a bad value? So traditionally in laboratory medicine, you'll get something like this. If you get a blood count run, you'll open up your medical chart and you'll see something like this where there's your test results, so 6.6 for white cell count, against a range, 4 to 10. And the range is in green for good and yellow for bad. It might be a different color if you have a different provider. But if you're kind of as a patient, I think it's very natural to ask, well, what does that mean? Like you kind of get, okay, green good, yellow bad, but what does good mean? What does bad mean? And I think if you're coming at this from a statistician kind of perspective, like I was when I first saw this, I went, well, wait a second. What on earth does normal actually mean? That's a really thorny concept. And so, what it typically means in laboratory medicine is a reference interval of a healthy population. Basically, you go out into the general population, you collect a bunch of samples of people that are presumably healthy. So you've screened them to make sure they don't have major diseases. I say presumably because you can't know if they have subclinical undiagnosed disease. If in 6 months' time they're going to get diagnosed with something, or they just have something that isn't really actively obvious. And what you do in that healthy population is you take a bunch of measurements and then you take the middle 95%. For some tests, it might not be 95, it might be 90, etc. But roughly, you get this middle range of what healthy looks like. And so that range, 4 to 10 for white cell count, is really just that interval, saying 95% of healthy people in our population, for our hospital, for our lab, have values between 4 and 10. And this kind of makes sense from an old, like when it was pen and paper, we needed a way to just benchmark. But this idea, I think, breaks down a bit in the modern age for a range of different reasons. Firstly, when we talk about interpretation, we have all of these limitations to this of using this as the benchmark. Firstly, it's not physiologic. If we look at the 95% range for hemoglobin, well, we're not ever really trying to say, do you have a healthy value? We're trying to diagnose disease, which is the inverse question. And so instead, shouldn't we peg a normal hemoglobin value to, well, when is it an indicator that you're likely to be iron deficient or another kind of driver of anemia? It's also low granularity, as I mentioned before. It's this kind of taking rich data and just treating it as yes or no, good or bad, healthy or not. And then I think the two big layers on top is that it's not context specific, that what a normal white cell count is very different if you are an inpatient who's just had open heart surgery versus if you are a outpatient. If you're a general doctor, a PCP, your internal reference for what is good for a white cell count is very different to if you're a cardiologist because you see different kinds of patients. And finally, it's not patient specific because most common laboratory tests have at least a small amount of heritability. And if we talk about the blood count and hematologic measures, most of them have high heritability. About 50% of the value is due to genetics and gene environment interactions. And so what is normal for me is not normal for you. And all of our current standards in how we interpret tests don't capture any of this. And so a lot of what the lab is focused on is really, well, questions of how do we build the frameworks to do better? So I'm really going to talk a lot about the second two pieces, the context and patient-specific reference intervals today. I've done plenty of work in the other two, and so if you're interested, reach out, email me, happy to chat. But let's start with the kind of general setup of why do we care about context or patient specificity? Well, why we care is because if we go measure, say, your white blood cell count, we're really measuring three interlacing things. One is a genetic component that your body regulates its white cell count around a certain level because of your genome, because of the various SNPs you have, because of gene environment interactions early on that primed your immune system. You also have this acquired component. Maybe your white cell count is a little bit higher because you have rheumatoid arthritis or another chronic inflammatory condition. And that condition isn't curable. It's just part of what the new normal for you is as you age and develop comorbidities, as we all do. Or there's the short term. You've just been hit by a bus. Your white cell count is through the roof because you've been hit by a bus. And so when we measure, we get one marker value for white cell count, but it's really telling us the three things simultaneously. And it would be nice to be able to decompose those because how we act on them is different. For the genetic component, we might talk about disease screening to say, hey, you're at elevated risk for this or that. Maybe we want to think about long-term behavioral modifications to mitigate that kind of inherent risk. For the acquired components, we're talking about chronic treatment. We're talking about adjusting treatment targets for you as you age and just reflecting what healthy aging is, that a healthy 50-year-old doesn't look like a healthy 20-year-old. And in the short term, we're talking about treatment. We're talking about giving you antibiotics or a transfusion or triage or diagnosis or detection. So we want to do different things with each piece. And so we want ideally an ability to separate out those three. So I'm going to start by talking about how we might do this for the short-term part. So this fellow here, a great friend and mentor of mine, Aaron Aguirre, he is a cardiologist. So most of the patients he looks at are in the first kind of 3 to 4 days post cardiac surgery. And he often described to me when I was a postdoc at Mass Gen, he would open up their chart and it was like they were screaming at him. All of these markers would be absolutely through the roof. Everything would be flagged as abnormal, etc. And he's just going, of course their white cell count looks abnormal. Of course their platelet count looks abnormal. Of course their creatinine's bad. They've just had open heart surgery. They've had their chest cut open, blood run external to the body, their heart stopped and had a major, major perturbation. And he doesn't need to know what healthy mean, whether they look like someone off the street. He needs to know, are they healthy relative to having had open heart surgery? So when we first investigated this question, we said, well, let's take all of these common markers, the white cell count, the other blood count markers. Let's take the metabolic panel markers, these other things that you measure in kind of every patient every day in the US. And let's take them and look at the kind of trajectories over the course of stay. So this is, for example, white cell count over about 5,000 patients. And you see there's a variance in where people start. They all get perturbed up at this surgery. You see this as this extremely clear shock event. And then there's a gradual relaxation back down as they recover from it. And there's a lot of mess and heterogeneity in there because, of course, there is its clinical data. And so we can take the kind of 20 most common measurements, the blood count and metabolic panel, and we can do some unsupervised clustering to go, what are the dominant phenotypes, the different ways you might recover? And for example, this would give us, say, 5 clusters. It doesn't really matter the exact number, as you'll see in a second, but it gives us a spectrum of phenotypic behaviors. And if we strip out the background noise and just look at the mean response, this is the mean response, 5 different trajectories where they're colored from the best outcomes in dark green through to the worst outcomes in dark red. And what you can see here is pretty sensibly the white cell count starts low, gets perturbed up by the surgery, and then recovers back down. Well, it does in the people in green who have really good outcomes. The people in red who have worse outcomes, as they start to recover down, they develop a secondary inflammatory episode. Maybe because they have an infection, have developed something septic, or they have to have a second operation because of some undetected internal bleeding that's caused a fever. And so you see this kind of spectrum of behaviors. But I think an interesting thing is you can actually see that there's not really a huge diversity of responses. There's kind of different gradations of the same response over time. And another way you can actually see that really clearly is if you plot markers against each other. So this is the plot of platelet count and white cell count. Why these two is because if you look at univariate analysis, they're the strongest predictors of things like mortality in this cohort, and also because they capture different speeds of dynamic response. So white cell count, white blood cells are really, really reactive. They migrate in and out of the tissues, and so your white cell count can go up and down really fast, and it captures that acute response to inflammation. Whereas the platelet count gets depleted in inflammatory settings as you form and dissolve clots, but then takes a long time for that population to recover. So it's a bit of a slower measure of your recovery. And so if you plot these two against each other, a la a kind of phase plane, again, injecting that like mathematical thinking without doing the kind of eigenvalue analysis of phase planes, etc. But if you plot those trajectories against each other, you see that there is this hysteresis loop, that the dark green starts in one spot, gets perturbed out, and follows back along this loop back to where they started. And the people in dark red, well, they get perturbed in reasonably similar ways, but as they start to follow back, they just don't seem to get back to where they started. And it turns out this hysteresis loop is remarkably consistent in the patients who do well. So if we just look at all the people who don't die, who don't come back to hospital, and who have a week or less overall hospital stay, a reasonable definition of good outcome, well, you have this hysteresis loop. And if you stratify that group by age, the nature of the curve is the same. They follow the same kind of trajectory. And similar if you stratify them by the ones who stay 3 to 4 days versus the ones who stay 6 to 7 days. And if you look at multiple medical centers, you get the same response. This is from Mass Gen and Brigham. I've also seen this at UW. It's the exact same response. If you stratify them by where they start, so if their platelet count is a little higher than normal or a little lower than normal, normalized to that starting point, the nature of the recovery response is the same. If you stratify them by preoperative risk evaluations, so the Society of Thoracic Surgeons has a general score they use to calculate mortality risk, conditioned on the patient having a good outcome, so conditioned on them not dying, the response curve they show is the same. And it's also the same if you stratify by different types of surgery, so bypass grafts versus valve repairs. And this is really, really interesting because it speaks to a more generalized response to acute inflammatory stress. And why is that useful? Well, because it gives us a reference point for what normal looks like for a given marker at a given time. So we can say, take that curve and we can go, well, where are you on day 3 or day 2 or day 1 relative to that curve? Where is your white cell count positionally relative to that curve? What direction are you heading in? Maybe your white cell count is decreasing, but it's not decreasing fast enough. Maybe the relative change in your white cell and platelet populations is not extreme enough. And if you use that as a dynamic reference, you get extremely strong risk stratification of your patients. It tells you a lot about what's happening to them because you're benchmarking them against what healthy looks like. And it turns out if they don't look like that, it's a really bad sign. And we kind of know this, at least qualitatively, in other areas of medicine. If you talk to a pediatrician, they do a lot of the time benchmark patients against nomograms for things like weight and height. And if you showed a pediatrician 2 patients, 2 boys, and they were both at around the same time, one was in the 90th percentile for weight and the other was in the 10th percentile, and you said a year later, one is still in the 10th percentile and the other is now down in the 50th percentile. The pediatrician's going to be much more worried about the patient in blue, the patient who has declined from the 90th to the 50th, even though they're still much larger than the other patient. And this is because we know that the relative dynamics are really important, at least qualitatively, that it's not just where you are, it is also the direction you're heading. And the cool thing is that this isn't just a cardiac surgery thing. If you look at other surgery types, you see this same hysteresis loop. It's a little bit different in magnitude. Different surgeries are going to perturb your body into different levels. Cardiac surgery is extreme. Something like a C-section is still obviously tough on the body, but it's less extreme. And we see this really consistently. And the cool thing is we can actually normalize these surgery types against each other to look at what the core underlying response is. And what we find is the platelet dynamics are really just relative to where your platelet count is on day, say, 1. Day 1, because you get a lot of transfusion, which will perturb you between day 0 and day 1 post-op. But your white cell dynamics, how fast your white cells come back down, really depends on how much they were perturbed. So there's a kind of inflammatory decay going. And from a mathematical perspective, what that tells us is that we have a linear response in platelet count and an exponential response in white cell count. Or in other words, you could imagine, hey, your white cell, well, what's happening is that you are perturbed up to some peak value from an initial set point that your body's trying to regulate around. And then you have some exponential decay at some rate kWbc in response to that. And what that speaks is to, well, maybe that exponential decay is due to the circulating lifespan of neutrophils, which dominate the white cell population, or to the half-life of various pro and anti-inflammatory mediating chemical signals in the bloodstream. But that gives us a kind of core dynamic. And for reference, K is about 0.5 here, I think, from memory, on average, which lines up actually with the known circulating half-life of white cells, of neutrophils in particular. On the other side, for platelet count, there's some sort of delay. It doesn't, the response has about a day of feedback delay in it, but the actual response of platelets is just linear. So if your platelet count drops in half, your body can't just absolutely ramp up platelet production. There is kind of a fixed level to which it can start producing new platelets to get you back to where you started. And that fixed level seems to be this kind of parameter K, uh, K platelet. And it's a linear kind of limit on how much you can produce. The cool thing of doing this is it gives us a way to normalize things across different contexts. So we can take all those surgeries from before, and we can, instead of expressing it just as white cell and platelet, we can look at the white cell relative to that model. So white cell minus our estimated set point divided by that, or normalized to that KWBC. And if we do that normalization, what we find is that all of these kind of inflammatory settings have fundamentally the same response dynamics between platelets and white cells. That there's a fundamental way that the hematologic system regulates itself in response to acute stress. And this isn't just a mean kind of property. If you look at the individual model of this at the individual patient level, the average R squared is about 0.85, zero 0.9. Again, all of this conditioned on patients that have good outcomes. Patients who don't have good outcomes go in all sorts of directions. There's many ways things can go wrong. But what this speaks to is there's only really one good way to modulate inflammatory recovery. And why that's really useful is it means that we don't need to think about the future as developing a benchmark for every laboratory test for every micro situation in the hospital. We could do a lot better than current standard by just having broad-based kind of nomogram reference points to say, well, broadly, if you're going through acute inflammatory perturbations, this is what it looks like, etc. The other cool little aside piece from this is that given we found that platelet and white cell dynamics were so consistent across these inflammatory settings, it makes sense to think that the ratio of platelet to white cell count, so that as a new marker, would be really predictive of risk across these settings. And that's what we find. For people with things like COVID or heart failure or stroke or heart attack, they're admitting the ratio between their platelets and white cell counts at admission is much more predictive of mortality and other kind of risk outcomes than just individual pieces of the CBC. So we can also kind of simplify that down to just say, well, also there are new markers we can learn from this process. So that's kind of where our thinking is with the context specificity to go, well, ideally, we would love to be able to construct dynamic benchmarks for different common major perturbations and major scenarios that hospitals face to say, this is what is normal for this marker for this kind of patient. But I think even more important than that is this other question about what is normal for a given patient independent of context. Because we know that a huge amount of blood markers are really highly heritable. This, for example, is a GWAS Manhattan plot, a genome-wide association study Manhattan plot of hemoglobin. Your body's hemoglobin level is extraordinarily heritable. About 50% of the variation in it is captured in, say, twin studies. And it's also extremely polygenic, that there's no one hemoglobin gene, there are 50 of them all across the genome, which makes sense. It's a really fundamental trait in basically all living creatures have some sort of blood carrying mechanism, or oxygen carrying mechanism. It's not always blood cells, it's not always hemoglobin, but it's a pretty fundamental trait. And this means that what is normal for you is kind of determined, at least in big part, and is very individual. And so if we look at patients over a long period of time and look at their isolated outpatient measurements, and by isolated, I mean their blood work that they get when they go to the doctor and they don't have other doctor's visits in the 3 months pre or post that, and to kind of give a proxy for reasonable health. Now, no one gets blood work done in perfectly pure health, but a lot of people will go to their yearly physical and maybe their doctor's a little trigger happy, so orders a blood test, or they go in for something really benign and the doctor orders it just to be certain. And so what that means is you do have a lot of data that is collected in relative health for these patients that you can use to understand kind of long-term variation. And you see this here with platelet count. So this is in black is just the platelet count trajectories for about 1,000 people over 20 years. And you see three trajectories we've highlighted. And each of these are just different patients in the cohort who have relatively stable platelet counts over that time period. And the dotted black line here is the population reference interval for platelet count, at least at Mass General, where some of this data was from. And what you see is each patient varies at a much, much lower level than that population variance. And so we can capture that. We can say, take someone's outpatient test history and try to use modeling to extract their set point. Now, why do we need a model as opposed to just taking the mean is because of these kinds of temporary disruptions that you happen to go to the doctor one day and had a cold. And so your white cell count is high. And we don't want to take that into account because it's not representative of health. So what we do is we say, take these patients that have long histories, take a Gaussian mixture model where we can decompose that history into 1, 2, or 3 normal distributions, find the dominant one. And that dominant one is effectively what their body is regulating around the majority of the time. And we don't just get the mean, the set point estimate, we also get a coefficient of variation or a variance or a standard deviation estimate that tells us, well, how well controlled is your set point? Because some patients will have better regulation than others. And I think a cool thing we see is actually that that coefficient of variation or that variance is effectively not related to the set point itself. That it's not that people with high set points have worse variation or vice versa. It's just in general, you have both a set point that your body's maintaining and also a level of homeostatic control that your body is achieving in terms of maintaining that set point. The other nice thing here is if we look at patients with, say, 20 outpatient measurements, so cream of the crop in terms of health, that you've been going to a physical once a year, getting blood work at that physical because you've had the same doctor and they're, again, a little trigger happy with ordering blood work. And so we have all of this data. Well, it turns out that we can get most of the way to your set point really, really quickly. That a single measurement, if it's isolated and outpatient, tells us within 10% what your set point is. And this makes sense if you look at this earlier graph. A single measurement from the blue, green, or yellow patient is a pretty good approximation of what their overall set point is. Any of the measurements from their time series. And at the very least, if I take your platelet count and it's 350, maybe your set point is somewhere between 300 and 400, but it's probably not 150. And so the current population range is so wide comparative to the individual level of variation that it means we can do so much with even just a single measurement. And so why do we care about set points then? Well, we care for a few different reasons. Firstly, they're generally prognostic in and of themselves. So if we take, say, if we take the white cell count or the hematocrit set point, etc., they are indicative of future mortality risk, including when you limit two values within the population normal range. So if you have a white cell count of 5 and I have a white cell count of 10, both ostensibly healthy for a population, and we're the same age and sex, I am about twice as likely to die of any reason in the next 10 years. Because my white cell count being elevated speaks to poorer homeostatic control, maybe speaks to an overactive immune system that's going to get me in trouble when something bad happens. Similarly, lower homeostatic control, so more variation around your set point, is also a bad signal. And all of these we validated at multiple medical centers, and we see this for all sorts of markers. It's not just blood count markers either, which makes sense. Most markers don't have a true physiologic cliff. They're a continuum. And so there is still risk within normal. This is also true not just for mortality, but for disease signals. So if you have a chronically low red cell count, that maybe speaks to some underlying clonality in your bone marrow population that means you're at higher risk of developing myelodysplastic syndrome or progressing to leukemia later in life. If you have a high white cell count set point, that maybe speaks to an overactive immune system that maybe is a precursor to development of autoimmune conditions. We see this across the board again, not just for these 6 diagnoses, but for a lot of diagnoses. And I think a thing to note here is that some of these ones are beyond the magnitude of commonly used cancer screening factors, like family history of certain cancer types. If for different cancers don't always produce the kind of 3, 4, 5% 5-year differences in rate or the doubling of risk that some of these factors do. So this is on par with potential and showing potential value for disease screening alone. Again, for a cheaply, routinely available test. The other thing that I think is the really important part is it can help us interpret new lab tests really well. If we take people who get a blood count test and also have iron workups, so things like their ferritin levels measured, well, the likelihood that they're going to be iron deficient based on that ferritin is dependent not just on what their presenting hemoglobin was, but also on how far did they drop from their pre-visit set point. So patients who dropped a lot in their hemoglobin from their set point are much more likely to be iron deficient. Why is this valuable? Well, it can help us better utilize tests to say, hey, this patient, maybe we don't need to order an iron workup because they actually haven't dropped much. But I'm probably more interested in the inverse of this to say, let's say you're a woman with a high hemoglobin set point. You could probably drop a fair bit and it's going to stay within the population level normal range. And so your doctor may not flag that as abnormal and may not think to order an iron workup. We could, in theory, build an auto alert system that just says, pops up to them and says, hey, you maybe want to consider running an iron workup because this person looks like they might be developing anemia. And we're actually going to be running some prospective studies around this over the summer, hopefully, to really dig in and see can we use things like this to better diagnose iron deficiency, particularly in women where it's chronically underdiagnosed. We also see this for other diseases as well, and not just these two. There's plenty of other use cases. We published a lot of this work at the start of this year in Nature, and so there's a couple of different use cases illustrated that I think are really valuable. So I think to kind of wrap it all up, I'd just say then, where do we go from here? Because the thing I'm proposing is not saying, say, with the patient-specific modeling, is to say burn it all down. Like, I'm not saying, hey, get rid of reference intervals, the kind of standard of how we interpret blood work tests across medicine, completely reroute and change how Epic works or other players. What I actually think is we need to work out targeted use cases. But before we can do that, we need better modeling frameworks because a lot of what I just showed was predicated on patients that you have kind of 5 or 10 years of outpatient testing history. And while there are actually plenty of patients that matters, it's not a given. It's definitely not the standard. And there are plenty of patients that wouldn't just can't achieve that level, particularly when you factor in challenges with interoperability of different healthcare systems in the US, that you don't have this public system where data sharing is easy. So where do we go? Well, what I would like to imagine is a kind of Bayesian framework where you can say, let's start with the population level reference interval when we have no data on you. And every time we get a data point, we could shrink that estimate down so that we can have a progressively refining estimate, meaning we can apply this model to everyone. It's going to do better on the people that we have more data in, of course, but it can be used and useful for everyone. It'll just get progressively better. And so a simple example would be you kind of assume that the set point is a normal distribution with a mean and a variance, and you use Bayes' theorem that every time you get a data point, you just refine that distributional estimate. But there's a big problem. People's set points can change. They are not truly static, at least in the concept of you have this interplay between a genetic kind of set point, like your body's ideal perfect regulation, and an acquired set point of, well, you have things that have happened to you that you can't undo that are just part of you now that you need to deal with. So a great example here, this is a woman who had a very clear low hematocrit set point for many years that then very suddenly shifted as she went through menopause, because it turns out this woman had menorrhagia, extremely severe menstrual flow during her periods, and so was losing a lot of blood, and that was having constant downward pressure on her hematocrit. And this is not a thing. This is someone who had dealt with this for multiple decades. This, you could call the severe periods a like chronic health condition, but it was very much like she was living a normal life going through this. Um, but this actually happens across the board with women. Most women don't have clinically diagnosed menorrhagia, but menstrual flow is going to put a downward pressure on many red cell indices because you are losing blood at a regular cadence every month, and losing iron in particular. And so we see that most women, as they go through menopause, their pre and post kind of diagnosis set point are different, but their hematocrit goes up. And so this, from a modeling perspective, brings in a big challenge because you want a model that doesn't over respond to new data points, because sometimes they can just be truly out of distribution. I show up to the doctor, I have a cold that day, so my white cell count is high, and I don't want that to affect my set point estimate. But conversely, you don't want a model to get too anchored to all this historic data if you go through a true physiologic shift. So what do you do? Well, you can add in some sort of, say, memory loss into the model to say, well, okay, let's weight new data points much more heavily than old data points by introducing some sort of parameter into our prior. And that then brings in a question of, well, how do you decide that weighting? Like, you can say a simple version would be an exponential weight back over your most X recent data points, but what is the slope of that exponential? If it's too low, we don't adapt to new data because we're too anchored to the past. And if it's too high, we're going to overcorrect to temporary disruptions. And so, to give you an example, on the left is a optimized lambda, and I'll speak through what optimization means in a second. On the right is an overly high lambda, where we're weighting recent data points too frequently, and we end up with an estimate that just kind of bounces around a lot. And I'll also say, sorry, as an aside, that a lot of this work is really being led by Cindy Zhang, a research engineer in my lab, who's doing phenomenal model development work. So how do we actually pick that lambda? Well, we would do things like, let's take a bunch of patients. So we took 10,000 with a lot of isolated outpatient measurements, and then let's look at the root mean squared error between each set point estimate at each point in time and the next isolated outpatient measurement they have, to say, well, how well does our model capture the next stable measurement of that patient, using RMSE for the set point, and then using things like the Kolmogorov-Smirnov statistic, the different for the variance. The KS statistic, for those who don't know, is illustrated on the right here, is the difference between a normal distribution CDF, cumulative distribution function, and the actual data. Basically saying, are patient measurements normally distributed around the patient's set point with the variance that our model predicts? Because if they are, then it's a really good estimate of variance. And it turns out there's a lot of statistical thorns in how you make sure that the variance estimate is really good, that I don't have time to get into, but I'm happy to discuss with people as interested. I'll also note here, we tried a bunch of different models, not just Bayesian models, but hidden Markov models, state space models, Gaussian mixture models, etc. We've been doing a lot of trying to work out what is the best model we can use for these kind of estimates, because before we want to push forward with clinical use cases that we really validate, we want to make sure that we don't have to go back later and change the model. We want to make sure before we try to get anything deployed that we really have confidence that we're capturing what we think we are. Cool thing is, it turns out all of these models do basically the same at estimating the set point, but some of them are better at estimating variance than others. And I think the broad takeaway is that a simple Bayesian model does a pretty good balance between capturing the set point and variance and not being super complex to parameterize, which probably is what we're going forward with, though we're still working out some little tweaks and questions with it. And I think a cool thing is that you see that the how well models fit is effectively a function of how individualized a marker is. that if you look at the ratio of within to between patient variance, often called the index of individuality, a marker where a value of one means that there's no real individuality to the marker. A value of zero means it's extraordinarily individual. Well, we have better error with the markers that are less individual, which makes sense. It's easier to fit things if there's not much variation at the population level. Okay, so finally, just to very briefly mention, where do we take this in a kind of translational sense? Well, there's all sorts of use cases. And as I said, I don't come in from a perspective of saying, let's burn the current system down and replace it with mine. I come in saying, let's find really targeted use cases where this doesn't just hint at utility, but has a direct translational action. So a great example is the iron deficiency study I mentioned to go. Can we build an auto alert system for deciding when we should or shouldn't order iron status workups? Another great example is prostate cancer screening. Prostate-specific antigen is highly heritable, and so I think there's an open question of, well, if you have a genetic predisposition to a high PSA, are you more likely to get unnecessary prostate biopsies, or potentially even to get to lead to a low-grade cancer diagnosis? And because prostate cancer is a very slow cancer most of the time, that wasn't necessary. You get biopsied at 70, you get told you have cancer, and it doesn't really go anywhere because if you biopsied 100 people, you would find some cancer in some of them, particularly for this slow acting cancer. And there are other interesting use cases around screening for blood cancers or predicting pregnancy outcomes because pregnancy has this huge hematologic perturbation because you have to produce a lot of new blood cells for the fetus. So I think there's all sorts of interesting use cases that we're starting to try to dig into for this. And so to kind of wrap it all up, I'd just say that a lot of the current standards we have are pretty crude and rely too heavily on a one-size-fits-all approach instead of being contextual and patient-specific and a little bit more refined in how we're thinking about it. And the cool thing is we have a lot of the data we need to allow for much more dynamic, patient-specific, context-specific interpretation, particularly for the lab tests that are the bread and butter of medicine, the things that we order in all sorts of patients all the time, and that are cheap, that are readily available, not just in the richest hospitals in the world, but in all sorts of settings. And on top of that, as I mentioned at the start, a lot of the clinical analyzers have much richer raw data streams than we realize. We're trying to archive this at UW so that we can use it for interesting purposes and try to explore it more. But that's a secondary layer to all this, is that we're not interpreting the simple markers well, but also there's all of this other untapped potential. And I think in general, to kind of the IMDS attitude, like there is a lot of room for computational approaches to help enable operational improvements here, to better diagnose or prognosticate or inform treatment for patients, and to also learn a lot of physiology along the way. So final slide before wrapping up is just to say the kind of where I think of the 5 to 10 year, not 5 probably to 10-year vision of this being realistic is you out there in the void, beautiful, wonderful you, black box that you are to me right now. Hate to break it to you, but something bad is going to happen in your life. You are going to have a stroke or a heart attack or an infection or be in a car crash. Sorry, hate to be the bearer of bad news. If it makes you feel any better, it's going to happen to me too. Turns out none of us get out alive. And the problem is when the bad thing happens to you, by the time you get to the hospital, you're already in the thick of it. You are actively inflamed. The bad thing is happening. Your body is panicking. And we don't really have a good standard right now to know where your treatment targets should be in that setting. But I want to imagine that down the line, we can say, well, actually, we have some data on you, and we can use that data to estimate a set point. And also, we know what's normal for a car crash or for a cardiac surgery or for that infection. And so we can combine those two together to really separate out those blood tests and say, well, here is the genetic component, here is the kind of acquired component, and here is the acute component. And we can then separate our treatment decisions and actually inform them by the piece that matters the most. And that's the kind of vision for this. Okay, so to fully wrap up, just say that research always takes a village and is highly collaborative, and I've been extremely lucky to be part of many, many great villages. In particular, I will highlight some of the work of Cindy Zhang, who's been doing a lot of model development for these methods, and Amber Chen, who has been doing a lot of great work with single cell data from underlying the blood count. I'll also just highlight that a bunch of the work I showed, I either started or sometimes finished while a postdoc at Harvard Medical School in John Higgins' lab. And he was a great mentor leading me through this work and continues to do great work in this space. But yeah, thank you. Happy to take any questions, etc.
Marvelous talk. Thank you so much, Dr. Foy. I think this is, anyone who's ever gotten a lab test drawn at any point can probably relate to this idea of, what's context dependent and what's patient dependent. Um, I'm happy to open it up to questions. I have a couple that I can start off with. Um, I was just talking to my parents about this recently, which was in the context of, my dad went in for a visit and got his blood pressure taken, and my mom remarked that, oh, it was pretty low. And my response to that was like, okay, low, like relative to what? Like relative to like what healthy is for everyone, or relative to like his history, etc.
Hmm.
Um, and so my thought was like, okay, well, his clinician is probably doing some mental calculus based on his knowledge of his chart. What have you seen from clinicians? I know you mentioned the one example of like the open heart surgery example, in terms of like how this fits into their own clinical paradigm of like what's going on in their head. Are they running these models more or less in their own head of like, what the set point is for a
So,
patient,
yeah. So look, I will say everything with the ego that comes with working on medical problems while not being a doctor and the understanding of that. I my glib answer would be the good ones are, but every doctor and every clinician likes to think they're the good one. Every patient hopes that their doctor is the good one, but there is a spectrum of clinicians, and not just in terms of like their skill, but also in terms of all of the things that they are juggling. The stressed out doctor at an underserviced hospital that has much less time to think about each patient is probably not doing that. And we see this emergently. There are of course treatment guidelines that are sometimes based on either reference limits or often decision limits, which are kind of adjacent but more targeted towards actual treatment. And but there are plenty of things that aren't. But we see meaningful spikes in clinician behavior just as you cross. If you look at a threshold analysis of, like, say, how often do you order antibiotics for a patient if their white cell count is 10.8 versus 11.2, if your institution uses 11 as the cutoff for
Mm.
normal, and you do see meaningful jumps, not like a smooth continuous gradient. And that does speak to, well, clinical thinking is definitely influenced by these population level limits much more strongly than I think some doctors will admit, though some do. I will also say plenty of doctors do think qualitatively about this stuff, but qualitative thinking is always dangerous because, again, it goes out the window when you're stressed and time poor. And unfortunately, we see through the history of kind of medical racism and things like that that it's not evenly applied to every population. Um, and so, what I really approach it from is this is a way to help systematize some of this. Again, I don't think of any of this as a circumventing. I always think of the best medical deployments are fully human in loop. And this I would put in the same bucket to go, what I want to do is do things like, hey, just put the thought into your head, like order that iron workup. Or actually, a really great study as a slight tangent from 2024, maybe 2023. I wasn't part of, looked at polygenic risk scores for white cell count, which is kind of analogous to set point, looking at the genetic basis more directly through modeling genetics. Um, and what they found is people with a genetic predisposition to a low white cell count were more likely to get bone marrow biopsies ordered and have those results come back negative. And unlike a simple blood test, a bone marrow biopsy is extremely invasive as a procedure. And it's absolutely terrifying to patients because they might have to wait 6 weeks under the suspicion that they have cancer. And so you do have really, really meaningful things that are currently happening in practice that are problematic that I hope that this kind of stuff, as it matures, can help address.
Sure. Absolutely. Yeah. Um, Thank you for that answer. If there's anyone who wants to put a question in the chat or come off mute, feel free. Um, but if not, I will ask another. Oh, okay. Please go
Sure.
ahead, Paul.
Sure. By the way, great talk and very thought-provoking. I have to ask one obvious thing. The beautiful work that you showed at the beginning about, what happens when people undergo surgery and this recovery process and how the trajectory is indicative of what the prognosis is. That sort of analysis, whether it was just looking at, that particular ratio or any number of biomarkers you might look at, um, seems like it could apply to any type of therapeutic event or any type of injury, whether it's a chemical injury or something like that, or a,
Yep.
daily event that happens in your life. And what you're doing is looking at a very, forgive me, obviously because of where you are, it's a narrow population, i.e., the people who arrived alive,
Yep.
okay, in the emergency room, and then were treated for some sort of
Yeah.
traumatic event or had a traumatic event, acting upon them
Yeah.
under the direction of a surgeon. Yet, if the goal is to stay healthy longer, it seems like these types of response curves, kinetic response curves of things, could be really diagnostic for people who are outside of the hospital. Is that, I mean, that's something I'm obviously interested in, but,
Yeah.
but any thinking about that so far?
Yeah. I think it's a good point. I think the broad answer, my broad gut would be in theory, yes, but we don't have the data. Like we're always limited by we don't have enough data. I think the closest that we get in the lab to thinking about this is kind of a new avenue we're looking at. And actually, one of my grad students, Yalin Amber Chen, is on the call here, is working on this. Is as I mentioned at the start, we're archiving a lot of the single cell data underlying kind of these routine tests and trying to get at the raw data streams because I think the answer is that a lot of the markers we use clinically are either by need or by design fairly crude. They are designed to detect big shifts. We look at, say, the mean red cell volume, and the mean will respond more slowly than, say, the tails of the red cell volume because when you start to lose blood cells, that you lose them either by the body producing less, say, in response to losses, which is going to be in the upper tail of volume because reticulocytes are bigger than average. So I definitely hypothesize that a part of a way to get around these kind of challenges is to actually look more sensitively at the kind of to develop markers that are specifically designed for early disease detection. Which, for example, in an outpatient setting, like you don't have it all the time in everyone, but what you do have is if you can tap into those kind of distributional data, you can get the tails, which may more sensitively tell you about disease. I think if you had the temporal data, you probably could do similar things in like at home. And I know you do a lot with, say, wearables and things like that. It's just a matter of it's hard to study it when you don't have the data. You also run into a positive predictive value problem where when the baseline rate of likelihood of disease goes down, the level of efficacy you need to hit in your prediction goes up to be useful, right? Just because otherwise you get drowned out by false positives, which is a hard problem. It's just a trade off.
Thanks.
Thank you for that question and that answer. Anyone else want to chime in with any questions, any comments? Another one I had is on if you've thought as far forward as like the implementation side of some of this work.
Mm.
So, personally, I know if you go into my chart these days, you can now see your own personal history of a given lab test.
Yeah.
And you can kind of think for yourself, oh, well, my my set point is lower than whatever
Yeah.
the population. Where do you see this actually like, kind of like,
Yeah.
yeah, crossing the barrier from lab to like a patient's hands or like a physician's toolbox?
Yeah, it's a really good question. So I'm actually right now I'm at the Association of Pathology Informatics meetings. So a lot of people who are kind of working on various problems in both anatomic pathology and clinical pathology, so which blood testing falls under, are thinking about kind of various ways of workflow improvements and information communication, all of this stuff. And I think some of the conversations I've had around this work here are really like there are a couple of different models, right? In terms of when you think about how you communicate this kind of information. One is to say, like, let's build a module into Epic that just visualizes the set point and the personalized reference range and let the clinician see that information and do with it what they will, right? That they can bring that into their gestalt and use that as they see fit. That's like model one. Model two is as I mentioned, kind of auto alerting systems, etc. Find a key decision point and say, okay, if I detect this patient's hemoglobin has dropped from their set point, and I detect that the clinician didn't ordered blood work but didn't order a iron workup, I'm going to alert them to say, do you want to do this? The third, which I think leans to what you brought up, is actually communicating this to the patient, which I think you have to be very careful about, but I think there's also a lot of value. Patients know their own bodies better than anyone else. And so you could feasibly say, actually, we're going to communicate to the patient and say, hey, your hemoglobin has dropped a bit from your set point. Maybe you should talk to your doctor about this the next time you get a chance and discuss whether it's worth doing a workup for anemia, right? Like there are gentle ways to communicate that. You have to, again, be very careful. Um, but I think there is a lot because fundamentally, you're always going to have the issue that a doctor just has far less time to think about the patient than the patient has, right? That they know their body better, and also they just have so much more time to think about their own health than a doctor does. And so there is some value in trying to go, can we empower patients? We're not there yet. I think where I really want to take this work in the next couple of years is really starting to flesh out these use cases, to start to go, are there the use cases that have enough signal to really, really justify as like a frontline implementation? Like, what is the three use cases that I think are the most valuable? And let's do some analysis to show that to really frontline the effort of implementation and deployment, at least at UW, if not multi-center, etc. And I think that's the pathway. So right now, it's like the next hopefully 2 years is find those use cases. Then the 2 years after that is start fighting the battles about deployment and also getting into the like UX and UI and who and where and when. Yeah.
Certainly not like an overnight thing, but clearly your team has already made a ton of progress. Um, Anyone else have any questions for our speaker today?
One sort of follow-on question. So again, I keep thinking about you view this from I will call it the ivory tower of the hospital. Okay. It means the data is people who are in the hospital for some typical, reason is that they need to be there. You know that already. But if you had the opportunity to get, information on the guy who comes in because of a motorcycle accident, okay? And you need to do surgery on this person and you want to know, are they going to recover? And if so, how do I know if they're recovering well? What information do you wish you had on that person, weeks, months, or years before they
Yeah.
ended up in the ER?
Yeah. So I think it's a good question. And I think there's a lot of things to unpack. Like I think obviously the data streams when people are in health, if we had true just healthy data on people, it would be phenomenal. Like someone asked me at one stage whether I would be like in favor of everyone at their yearly physical gets blood work no matter what. And I'm very much not. I actually think we overtest in the US in general. But I think what I would be in favor of is sometime between the age of 18 and 30, when you're pretty healthy, you come in once to your doctor and you get blood work done for the 40 to 50 most common analytes. And that's not 40 to 50 tubes of blood, that's just like 4 tubes of blood because most of these are panels of tests. And just because we know that at some point in life, we're going to need to benchmark what your CBC is, what your metabolic panel is, what your magnesium is. Like, we know what the common things we care about are. And having a single measurement would be a order of magnitude better than the current standard we have. As I showed before in the talk, if you knew someone, a single platelet count measurement from someone in relative health tells you probably 80% of what their set point is. Now, it doesn't account for things that like chronic disease and drift, etc. There's more to unpack, but I think even just that one would get you really far. Um, like, more data would be better, but there's a trade-off. Like, it takes time, and also as you start to think about collection outside of the hospital, you get into a more biased population, right? Like, you are preferencing, even if we're just say within the US, you're preferencing typically, like if you look at say Fitbits, etc., which like I have one, but you're preferencing to like upper middle class and above and whiter populations, etc., let alone the fact of, okay, we're actually even just limited to places like the US or Australia, as opposed to countries that have more resource limits in their healthcare and in their population. Like, a big reason why I care so much about the blood count is because it is one of the few tests that is run everywhere in the world in every patient population, which means that you don't need this $10,000 sequencing test to do something. If you can do something with the blood count, you can do it in rural India just as easily as here. And I actually have a lot of collaborators with a distributed healthcare setting in rural India that we're working, not just rural India, across India, that we're working on projects with kind of comparative analysis. But like that, I think, is the higher level as well. That we just can't rely on that data access across general populations as much as I would love to.
Do you, I mean, foresee a future like where, as you said, you're wearing a Fitbit right now, wearables are getting more and more popular. You know, every so often there's like a wellness kind of startup or someone kind of pitching the idea of daily tracking or very personalized medicine. Do you see this becoming a routine part of or a segment in like the electronic health record where you have maybe a very small subset of the population, but one where you have way more granular measurements? Or do you think, you know, the set
I,
point's the set point and like you don't need such
yeah.
granularity to get that?
I think and I kind of alluded to this, and I know Paul on the talk on the call here does a lot of work in the kind of at-home testing space, which I think is really interesting. I do think the positive predictive value problem is really, really hard, right? If you're doing, say, a test once a month in a person who's relatively healthy, well, the sensitivity you need to have to make sure that your positive predictive value is high enough is really, really a hard bar when the likelihood that they have disease is low. Like, the whole point of if you have a testing, even as an outpatient, is there's some conditional increased likelihood that they have disease because they came to the doctor, right? And so you're actively looking for a problem that you think is there, as opposed to looking for a problem that you have no clue if it's there or not. Which is not to say it's impossible, but it's just a much harder problem. You need to operate with a much higher level of specificity. Um, Look, I think that like the maybe the middle road answer is that if we really do if we really do find use cases and find that the signal is extraordinarily strong for certain use cases, it probably increases some motivation that, hey, maybe every other year your yearly physical should have blood work tied to it, as opposed to just it only has it if your doctor decides they like ordering blood work. So I genuinely don't know. I think it really just depends. Do you find the use cases that motivate? I think there is all sorts of other interesting work in terms of integrating wearables, that data that does exist into kind of medical prediction, but that's well outside the scope of what we kind of focus on. Interesting and hard problems, but yeah.
Yeah, no, thanks for engaging with that hypothetical. I'll yeah open it up once more if anyone would like to jump in. Going once. Going twice. Okay, well, thank you again so much, Dr. Foy, for this talk. I think it generated a lot of interesting discussion. We've also recorded it, so this talk will be made available on the IMDS website. And look out for our next talk, which is on let me just double check. On June 3rd, we'll be having Eric Hurwitz, who's a postdoc at UNC Chapel Hill. Thanks to all our attendees, and thanks again to Dr. Foy for the talk today, and we will catch you next time. Have a good evening, everyone.